Good evening, Dr. Phil here. Today we will be discussing on pulmonary edema. Pulmonary edema is defined as the extravascular accumulation of fluid in the tissues and air spaces of the lung. It is formed by movement of that fluid across capillary membranes. A number of factors contribute to this fluid flux across the capillary, interstitium, and into the alveolus. These factors are governed by the Starling's hypothesis for capillary fluid exchanges. Starling Equation. Fluid flux equals capillary filtration coefficient times capillary hydrostatic pressure minus interstitial fluid hydrostatic pressure minus reflectance coefficient times capillary oncotic pressure minus interstitial fluid oncotic pressure. K is capillary filtration coefficient, which is a proportionality constant which is a measure of the ease with which fluid traverses the endothelial boundary. It is a product of the area of the capillary wall times the permeability of capillary wall to water. A high filtration coefficient results in high leakiness of capillaries. PCAP is capillary hydrostatic pressure. In a standard systemic capillary, it is usually 30 mm mercury in the arteriolar end and 15 mm mercury in the venous end. PIS is the interstitial hydrostatic pressure. In the standard systemic capillary, it is usually 0 mmHg. Delta represents the reflection or reflectance coefficient. It indicates the permeability of the capillary barrier to solutes to act as a semi-permeable membrane. Delta equals 1. There is total reflection with no solute passing into the interstitium. Delta equals 0. Free passage of solute occurs through the capillary wall. Pi CAP represents the capillary oncotic pressure. In the standard systemic capillary, it is usually 25 mm mercury. Pi IS represents the interstitial oncotic pressure. In the standard systemic capillary, it is usually 5 mm mercury. The net sum of the four forces usually forces intravascular fluid outwards. This occurs even in the pulmonary circulation, where hydrostatic pressures are lower than that in the systemic circulation. Extravasated fluid is cleared by lymphatics. Normal clearance rate is 10 to 20 mL per hour in the lungs. Clearance can increase to 200 mL per hour before the system is overwhelmed. This equation does not account for active transport of solutes and effect of surface tension in the lung. Oncotic pressure, also known as colloid osmotic pressure, it is the contribution made to total osmolality by colloids. At 25 to 28 mm mercury, the plasma oncotic pressure is only about 0.5% that of total plasma osmotic pressure. It is the only force whose effect is to retain fluid within the pulmonary capillary. In the supine position, normal PCAP is 25 mm mercury, normal COP is 28 mm mercury. These two forces are roughly matched. Pathophysiology of pulmonary edema. Increased capillary hydrostatic pressure is common. Examples include left ventricular failure, such as due to myocardial infarction, valvular heart disease, arrhythmias, malignant hypertension, etc., pulmonary embolism, external pressure by a mass which reduces venous return, fluid overload, mitral stenosis, constrictive pericarditis, and neurogenic pulmonary edema, such as during subarachnoid hemorrhage, where there is an increase in capillary hydrostatic pressure from catecholamine surge. PCAP at dependent parts of the lung is more than the capillary hydrostatic pressure at non-dependent parts. Second mechanism is decreased interstitial pressure. Pulmonary edema may develop as the lymphatics are overwhelmed when the interstitial pressure becomes acutely negative, such as during upper airway obstruction. Massive increase in negative intrathoracic pressures may be generated, creating a gradient which favors transudation. Decreased capillary oncotic pressure. This can occur during hypoproteinemia, such as due to malnutrition or protein-losing enteropathy, hypoalbuminemia, liver failure, nephrotic syndrome, and hemodilution. There is a decrease in the gradient between the oncotic pressure and the pulmonary capillary occlusion pressure. Edema formation is eminent if this gradient does not exceed 4 mmHg. Albumin makes a substantial contribution to colloid oncotic pressure. Pulmonary edema will develop if plasma albumin concentration times 0.57 is less than PCWP. Reduced reflection coefficient. Capillary endothelial injury causes delta to become zero. Protein diffuses freely across the capillary wall such that no effective oncotic pressure can be exerted. There is increased permeability to water and increased filtration coefficient. Conditions such as ARDS can cause capillary endothelial damage. Decreased lymphatic clearance is uncommon. It occurs in diseases which obliterate lymphatic vessels, such as in severe lung fibrosis, silicosis, lymphangitis, carcinomatosis, post-radiation, and cancer. Mechanism uncertain. Increased altitude, possibly via pulmonary vasoconstriction. Rapid lung re-expansion after atelectasis, such as after pulmonary surgery or re-expansion after a pneumothorax. Thought to involve local changes in capillary pressures and permeability. Naloxone-induced, thought to be due to catecholamine release, and opioid overdose, thought to be due to decreased vascular permeability. Interstitial edema increases until pulmonary edema occurs as fluid clearance mechanisms are overwhelmed. Frothy edema fluid fills the airways, gas exchange is impaired, narrowing of airways and pulmonary vessels occur, resulting in reduced FRC and reduced lung compliance. Clinical features. Symptoms include dyspnea, autopnea, pink frothy sputum, and symptoms of the underlying disease. Signs includes a distressed patient, pallor, sweating, tachycardia, tachypnea, autopnea, cough with pink frothy sputum, pulses alternans, increased JVP, fine lung crackles, triple or gallop rhythm, wheezing, posture, sitting up and leaning forward, features of respiratory failure and signs of underlying causes. Investigations. Chest X-ray. Features of the underlying condition may be seen. Pulmonary edema features includes fluffy radioopacities at perihilar in left ventricular failure, patchy and peripheral in ARDS. There are thickened bronchial and vascular markings. Curly lines may be seen. Curly A lines are thin oblique unbranched lines 2 to 6 cm long, less than 1 mm thick. It radiates from the hilar and represents thickened anastomosis between central and peripheral lymphatic vessels. Curly B lines are transverse lines less than 3 cm long, seen at lung bases, especially at costophrenic angles. It extends out to the pleural surface lying perpendicular to it. It represents thickened interlobular septa due to pulmonary edema, fibrosis, or tumor. Curly C lines are short reticular fine lines that do not reach the pleura. They do not extend radially from the hilar. They are not commonly seen and represents thickening of anastomotic lymphatics or superimposition of many curly B lines. Curly D lines are equivalent to the curly B lines but seen on lateral chest X-ray in the retrosternal air gap. Differential diagnosis for curly lines includes pulmonary edema, neoplasm, pneumonia, fibrosis, sarcoidosis, and pneumoconiosis. Fluid in the transverse fissure may be seen. Other investigations include ECG, urea and electrolytes, troponin, arterial blood gases, which may show hypoxemia, hypocapnia from hyperventilation, and metabolic acidosis if severe. Echocardiography, BNP, pulmonary capillary wedge pressure, helps in differentiation between hydrostatic and other causes. It is normally 6 to 12 mm mercury measured at end expiration. With normal colloid osmotic pressure, pulmonary edema is likely if PCWP exceeds 18 to 20 mm mercury. Alveolar fluid protein content and total lung water content via radioactive or dye dilution techniques are rarely used. Rational management. Treat the underlying condition. Decrease left atrial pressure. To treat hydrostatic pulmonary edema due to increased capillary hydrostatic pressure. Offload left ventricle using nitrates and ACE inhibitors. Acute left ventricular failure treatment. Sit the patient upright. Take a short history and concise examination. Continue treatment while assessing the patient. High flow oxygen if decreased SpO2. Maintain 94 to 98%. If COPD, aim for 88 to 92%. Avoid oxygen if not hypoxemic, as oxygen can cause vasoconstriction and reduce cardiac output. If COPD but hypoxemic, Give supplemental oxygen but monitor for CO2 retention and desaturation ASAP. Obtain IV access and request for investigations as in the previous section. Close monitoring includes ECG, treat arrhythmias promptly, vital signs such as blood pressure, pulse, respiratory rate and temperature, cyanosis, JVP, urine output, monitor ABG, cardiac monitor for arrhythmias and ischemia. Diamorphine 1.25 to 5 mg IV slowly, caution in COPD and liver failure. IV morphine 1 to 5 mg is an alternative to diamorphine. Furosemide 40 to 80 mg IV slowly, renal failure patients require increased doses. GTN spray 2 puffs sublingually or 2 times 0.3 mg tablet sublingually. It is contraindicated if systolic blood pressure is less than 90 mm mercury. Nitrate infusion if SBP is more than 100 mm mercury, such as IVI isosorbide dinitrate 2 to 10 mg per hour, maintain SBP 90 mm mercury or more. Intermittent positive pressure ventilation may be required. PEEP improves gas exchange. If the patient condition is worsening, administer furosemide 40 to 80 mg, apply CPAP, increase nitrate infusion while keeping SBP more than 100 mm mercury. Consider alternative diagnoses such as hypertensive heart failure, aortic dissection, pulmonary embolism, pneumonia, asthma, COPD, etc. Volume overload patients, consider venesection and removal of 200 to 500 ml of blood. If SBP is less than 100 mm mercury, treat as cardiogenic shock, administer oxygen, diamorphine, investigations as mentioned, close monitoring, correct arrhythmias, electrolyte abnormalities and acid-base imbalance, assess filling pressure by pulse, BP, JVP, ultrasound, Doppler, CVP, if available, PICCO, LIDCO, and Swan scans catheter. If the patient is underfilled, administer IV plasma expander, 100 ml every 15 minutes, aim for MAP of 70 mm mercury and CVP of 8 to 10 mm mercury. If the patient is well or overfilled, administer IVI dobutamine 2.5 to 10 mcg per kg per minute, aim for MAP 70 mm mercury, treat reversible causes such as thrombolysis for MI or PE, surgery for acute VSD, MR, AR, etc. Refer for ICU care. If the patient's condition is improving, daily weights, aim reduction of 0.5 kg per day, chest x-ray, change IV furosemide to oral furosemide or bumetanide, add thiazide if on large doses of loop diuretics, ACE inhibitors if left ventricular ejection fraction is less than 40%, hydralazine and nitrate if ACE inhibitors are contraindicated, beta blockers and spironolactone if left ventricular EF is less than 35%, treat AF if present, consider biventricular pacing, cardiac transplant, anticoagulation in AF, dialysis for fluid extraction, etc. Increase myocardial contractility by using inotropes. Decreased capillary oncotic pressure, usually contributory rather than primary, albumin. It is the most abundant plasma protein and it maintains plasma oncotic pressure. About 80% of the colloid oncotic pressure is attributed to the albumin concentration in plasma. Other physiological roles include it acts as a buffer, transport of molecules such as bilirubin, hormones, fatty acids, drugs, etc. and it acts as a free radical scavenger. Molecular weight 69,000, normal plasma levels 35 to 50 grams per liter, synthesis by the liver, removal from the plasma into the interstitial fluid, it passes via lymphatics back to the plasma or into cells to be metabolized. Depletion occurs in critical illness such as infection, trauma, and shock. Albumin IV infusions. It is used as colloid in IV fluid therapy for critically ill patients. No improvement in outcome has been found when compared with cheaper alternatives. Albumin 5% is safe to be used as resuscitation fluid, except in patients with traumatic brain injury. There is increased mortality in patients with traumatic brain injury when IV albumin is used. Colloid fluids such as albumin contain large molecules that do not readily move out of the vascular compartment. These molecules create a colloid osmotic pressure that promotes the retention of water in the vascular compartment. Colloids tend to preserve the plasma COP. 70% of infused colloid fluid is retained in the vascular compartment, which is more than 3 times more effective than crystalloids in increasing plasma volume. Concentrations available for albumin includes 4%, 5%, 20%, and 25%. 5% albumin solution is hypooncotic. COP is 20 mm mercury. It is given in aliquots of 250 ml. It results in at least 70% retention in plasma. This volume effect begins to dissipate at 6 hours and is lost after 12 hours. 25% albumin solution is hyperoncotic. COP is 70 mm mercury, which is 2.5 times that of plasma. It is given in aliquots of 50 to 100 ml. The increase in plasma volume is 3 to 4 times the infused volume. Interstitial fluid is drawn into the intravascular compartment. Duration of effect is 12 hours. It should not be used for volume resuscitation in acute blood loss, as lost volume is not replaced. It is useful in patients with hypoalbuminemia and edema who are hypotensive and resistant to diuretics. Albumin is the most expensive non-blood plasma substitute. Hypoalbuminemia in critically ill patients is usually a result of increased metabolism of circulating albumin. IV albumin infusions does not generally result in maintained plasma albumin levels. Unless the patient's critical illness improves, plasma albumin concentrations can't be maintained. Increased alveolar pressure. Role of PEEP in pulmonary edema. There is increased capacity of the pulmonary interstitium to hold fluid. Increased PEEP of 1.5 mm mercury results in accommodation of 500 ml of fluid in pulmonary interstitium. It is a useful therapy following negative pressure pulmonary edema secondary to airway obstruction. Introduction to positive and expiratory pressure. PEEP is an elevation of alveolar pressure at the end of expiration. It can be divided into applied PEEP and intrinsic PEEP. Applied PEEP is created by a pressure relief valve at the end of expiratory limb of the breathing circuit. It allows expiration to proceed until a pre-selected pressure is reached, and this pressure is maintained until the next inspiration. Intrinsic PEEP occurs as a result of ventilator settings interacting with the patient's respiratory system mechanics, thus producing long expiratory time constants. PEEP of at least 5 cm H2O prevents collapse of small airways at the end of expiration. PEEP limits atelectroma. It is usually kept at 5 to 7.5 cm H2O unless there is oxygenation failure. It does not appear that outcomes are influenced by use of high rather than low PEEP. Incremental increases in PEEP can improve arterial oxygenation when FiO2 exceeds 60%. FiO2 of more than 60% is potentially toxic. Maximal safe level of PEEP is reached when plateau pressure reaches 30 cm H2O. PEEP should ideally be done with reference to the static pressure volume curve. The upper inflection point represents probable encroachment on total lung capacity. Inspiratory pressure should be below this point to avoid overexpansion. At the lower inflection point, small airways and alveoli open, which is equal the closing volume at this point. The inspiratory pressure should be just above this point to avoid alveolar derecruitment. Inflection points are often difficult to identify on pressure volume curves produced by modern ventilators in day-to-day practice. To reduce the peak airway pressure for a given mean airway pressure and to minimize intrinsic PEEP, pressure-controlled ventilation should proceed on the steep linear part of the curve midway between the two inflection points. Caveat: PEEP that is appropriate for one lung region might be suboptimal in another lung region and excessive in another lung region. This is due to the heterogeneous nature of parenchymal lung injury. Optimizing PEEP is a balance between recruiting recruitable alveoli in diseased regions without over-distending already recruited alveoli in healthier regions. Advantages of PEEP: it prevents alveolar collapse at the end of expiration. It improves oxygenation and VQ matching. Collapsed alveoli can't participate in gas exchange. It limits atelectroma. Patent alveoli have less risk of injury from shear stress of repeated opening and closing. It improves compliance by preventing surfactant breakdown in collapsing alveoli. PEEP can be used in alveolar recruitment maneuvers. There is increased capacity of pulmonary interstitium to hold fluid. Disadvantages of PEEP. It causes increases in end inspiratory alveolar pressure and mean airway pressure. PEEP should not be increased beyond P plateau of 30 cm H2O to avoid ventilator-induced lung injury. There is decrease in cardiac output. PEEP increases mean intrathoracic pressure, resulting in impaired venous return, increased right ventricular afterload, and external constraint of ventricles. This is exaggerated by hypovolemia. It is mitigated by fluid infusion. Decrease in cardiac output can cancel the benefits of PEEP in improving arterial oxygenation. Central venous oxygen saturation should decrease if there is a PEEP-induced decrease in cardiac output. PEEP that is appropriate for one lung region might be suboptimal in another lung region and excessive in another lung region as mentioned above. These are my references. Thank you.